Hi, everyone. I'm Darlene Hutton with QRS Educational Services, and welcome to part 4 of our 7-part series titled Airway Management. This has been designed for nurses, especially those of you who work in more rural or remote hospitals where you don't have the luxury of having an RT available, and you may have one physician that's going to be doing the intubation for the patient. All of the team at this situation would be wearing personal protection, and somebody will be managing the patient's airway while we get ready to intubate. So just to remember, if we have an oral airway with a bag valve mask, if this is a respiratory arrest, you will be doing 1 breath every 6 seconds. If this is a cardiac arrest, we will be doing 30 compressions, and at the 30 compression, we will then administer 2 breaths, and then we will resume the next 30 compressions, and we'll do 5 cycles of that for a 2-minute period of time. So while that is happening, we will be preparing for our endotracheal intubation. If you haven't yet had a chance to look at the 3rd video series in the series, it's called Slope, and it's a reminder of the different things that we need to get out of the crash cart or the airway cart to ensure that we've got all of the equipment ready. So we're going to take a quick look. We've already established we have our suction, and it is attached to the suction machine. We have our sedation, not necessary in this particular case. We have our stethoscope. The stylet, get it out, get it ready. And in this particular case, I'm going to ask you to put it into the endotracheal tube and give me a hockey stick shape. So what you're going to do is you're going to insert it into the endotracheal tube without extending outside. And this is the shape that you are looking for. And that will facilitate the tube going up past the vocal cords into the trachea. The other thing that's really helpful at this point also is to have your syringe attached with the air. I've already checked that there is no cuff leak, so that's been established. I'm just going to attach this so it's ready to use. Okay. You want to have all of your equipment on the right-hand side of the person doing the intubation, and the reason for that is when we go to insert the laryngoscope, we always have to hold it in the left hand. And the reason for that is the way the laryngoscope has been developed. There's a little crest here, and that's to facilitate the endotracheal tube sliding in that direction. So everything is going to be handed over to me from my right side. So we're ready to start the process. If we're doing compressions, I would ask to stop the compressions. It should take no more than 10 seconds. As soon as the tube is past the vocal cords, I would say resume CPR. So we're going to take out the oral airway and make sure at this point that you have well lubricated the endotracheal tube. Whoops. Go. So that's ready to hand over. And I'm going to go very slow through this process so you can see step by step. I visualize the cord, so I'm going to have you, or I'm just going to grab it myself. You've given me the shape I want, and I'm going to insert this so it goes past the vocal cords. I have seen it go past the cords. I know it is in the right spot. So it's really important at this point that I anchor the endotracheal tube against the face so that I don't lose that position. We are going to take out the stylet, and this is the point in which I'd say resume CPR. Going slowly, we're going to make sure that we connect everything. Next, so filters always first. Next, we're going to put this colorimetric carbon dioxide detector on. If you don't have end-tidal CO2 capability right away, this is what you're going to use instead. And I know many of you, this is what you have as your first choice. When you open it up, it will be purple on the inside. Okay. And now you're going to attach your ambu bag. And you can see why you need a couple of sets of hands. Before that, we are going to ensure that our cuff is nice like a soft grape. And you may not require 10 cc's of air, but you just want to make sure this is a soft grape. Also ensure that you've disconnected your syringe, otherwise air will leak back out. Now we connect the ambu bag. And we're going to do a 5-point check with the stethoscope. So you may be the one that's auscultating while I administer the breaths, or I may be the one auscultating while you administer the breaths. But the first breath is to ensure that there is no air heard going into the stomach. The next two breaths are to ensure that I hear air entry equal on both anterior lungs. And the last two breaths are to ensure that there is equal air entry in both lateral lung fields. So now that I know and I've confirmed that air is going into the lungs, I will see that this color cartridge will turn yellow because the exhaled carbon dioxide reacts, and that's what turns it from purple to yellow. So if this patient is respiratory arrest, I would now be doing one breath every 6 seconds. If this is a cardiac arrest where I'm doing compressions, the compressions would now be continuous, and I would be doing a breath every 6 seconds. As soon as you are able to put the patient on continuous waveform capnography, what we are going to do is we are going to disconnect the ambu bag. We're going to take off this cartridge, and we are going to attach the end-tidal CO2. And this is just one example of what you have available. I've seen different ones in the hospital. Reconnect, and anytime you do a change, anytime you do something new, you always need to reassess that things are still in the same location. So you want to continue to do that 5-point check. You're going to hook this up to the monitor, and that's what's going to produce your continuous waveform capnography. And for a patient who has a good cardiac output, they should have an end-tidal CO2 reading of about 35 to 45 millimeters of mercury. If this is a cardiac arrest and you're doing compressions, you should have an end-tidal CO2 reading of greater than 10 to ensure adequate compressions. So that's about it for the endotracheal tube, but I do want to talk about the patient who has a difficult airway. And for that, I'm just going to disconnect. Take out the endotracheal tube. Okay. And for this next, I'm going to make sure that it's still well lubricated. We're going to talk about the role of the bougie. This will be in your cart, so make sure you're familiar with it. Don't use it all that often, but if you're asked to, it's got this angle tip at the end, and this is what you're going to hand over to me. It is for difficult intubation. So what that means is I can't readily see the vocal cords. This is a difficult patient. So you are going to hand this over so that the tip is facing upright. And I may or may not see it go in past the vocal cords, but this now becomes an introducer. So what you're going to do is you're going to take the tip of the endotracheal tube. Just take the filter off so you can see well. Okay. And it is helping to introduce the endotracheal tube in. You now take out the bougie. You go through the motions again. You attach your filter. We'll attach the end-tidal CO2 to the monitor. We attach the ambu bag. And now we're going to do our 5-point check to make sure that the air is going in the lungs and not in the stomach. Okay, so that's the role of the bougie. Oh, and I forgot to use the syringe to inflate. So that's why there wasn't great air entry. So if we do put that seal in, you'll be able to see the difference in how the lungs expand once you have a good seal, okay? So that's the bougie. The reason why we don't see the bougie used a lot is because most of you have GlideScopes in your hospital. And the GlideScope is a great device. This is one example. You can see the hockey stick shape to it. There would be a light source over here, and you can visualize the cords. Many of you have a bigger GlideScope that's on a stand, and it may have a monitor that's this large. So please take an opportunity to look at what the vocal cords look like, because that is what is being targeted to pass the endotracheal tube through. So I think we've talked about everything that I needed to cover with you in assisting with intubation. If you like this video, please give me a thumbs up and subscribe to my other videos as well. In the next video, we'll be looking at insertion of the laryngeal mask airway, another video on insertion of the King LT, and the last in the series, we'll be looking at continuous waveform capnography. Thanks again.